Right, everybody, welcome again to Let's Talk with the Doc. I'm excited that you join me on another Wednesday evening, and I am as excited this evening as I have ever been because of the gentleman that I have joining me on this particular Let's Talk with the Doc. I am excited to have Dr. Raymond Wedderburn, and there are so many things that we're going to talk about, and I'm sure that you will learn something and it will inspire you. And if you have aspirations and dreams and you're looking at possibilities and what you can pursue in life and whether you can achieve those things, Dr. Wedderburn will inspire you and tell you his journey so you will know what example to follow and pursue your dreams. When I come back, right back, I will be talking to Dr. Wedderburn. So stay tuned, my friends. ORB Ministry presents Let's Talk with the Doc. Grace Without Borders podcast. A thought for you. Ask Pastor. And a whole lot more. You never know what's next or who will join the conversation. All right. So if you join me now, my friends, and the first thing to do is to make sure you hit your share button if you're just joining, because if you're on YouTube or on Facebook, I want all of your friends to know about this great man who has given his time and profession in an unselfish way, and you will hear for yourself at least that which we will be able to glean from. I promise you an hour and a half, 2 hours. I would need maybe 5 hours just to go through the history of this man's contribution to society. So thank you for joining me. And Dr. Raymond Wedderburn, good to have you, sir. Welcome to Let's Talk with the Doc. I am excited to have you with me. As I said in the green room, as we normally say, I am so happy I had to use a net to catch a single fish, which is not the norm. But if that's what it took, then I'm excited just to have you. Welcome to Let's Talk with the Doc.
Thanks for having me.
I am so excited, man. I'm excited to have you. How has your day been?
It was a good day. We Wednesdays are conference day, so it started off with conference this morning, and then I had to see some patients, and I did surgery. Managed to get out on time and make it home in time to log on. So it was a very good day.
So you actually did perform surgery today.
I did, yes.
Oh my goodness! I'm not going to ask what that surgery was about, but I tell you, man, I'm excited to have you. All right, so um, starting from the beginning, I think that's what you like to start from the beginning. So I like to hear from my guests. A little bit of their story, growing up, where they were born and what their lives were like in the early stages, their siblings, their early school days. When did they come to the aspiration, or when did you know that, hey, this is what I want to become? So tell me a little bit about your own story in those infancy young days when you were just running around, not a clue of what life is going to be like.
Yeah. So born in Kingston, Jamaica, Victoria Jubilee Hospital,
Oh,
under the clock,
gee,
as they
all
say.
right.
Born
Another
under the
tag,
clock.
right? Yeah,
Uh,
right.
Grew up in Kingston. I attended Calabar all-age school, so they kicked me out of the house when I was 3. I was asking too many questions, so I think my parents decided it was time for me to go to school and ask someone else the questions.
So, so they sent you to school from you were 3 because you were too curious.
I was too curious. And so, coming through like in primary school, I enjoyed learning. So I didn't know what I wanted to do at that point. But it's kind of interesting because, as most kids go through the phases of these different things that they want to be and they change their mind and so on. I always say that I ended up in medicine for no good reason, in the sense that it wasn't as if I had, great experiences with, physicians, or there were physicians in my family. It's just one of those things that, I came on and it was sort of, well, that's an opportunity to help people. And even as a youngster, I said, well, that's a good thing to do. And so I told my parents that was, what I wanted to do. And they sort of said, well, yeah, why not? And something, I think that one of the good things of growing up in a place like Jamaica, I mean, as opposed to the States, although the opportunities are here, is that all of these things seem achievable, because when you look around you, you see people who look like you doing them.
Right.
So it never really crossed my mind that I couldn't do it. And so, I went to school, went to women's boys school until 4th form, and then we moved to the States. And I have to tell you that by the time we came over, it wasn't absolutely clear to me that my dreams could have been realized in Jamaica, because there's just one medical school. It's the University of the West Indies. It's not just for Jamaica, and so lots of competition. There are people who have money, have more influence, who will have more opportunity, and so coming to the States and then seeing what was available, if you were willing to, work as hard as possible. Was kind of the key move. So once we got here and I saw the opportunities, I applied myself, and I think through hard work and opportunity was able to go to college and medical school, and and then go on to pursue my career in surgery. And that's kind of sort of like, that's a synopsis of it. But in terms of like the rest of like the family piece of it, it's just I think that having come this far and kind of looking back on it, and also in all my travels, I realized that kind of the secret to this whole thing is that is family. Because at the end of the day, everyone wants sort of the same things. People get up in the morning, they send their kids to school, they go to work, you come home, and you want to have a roof over your head, right? Be able to feed your family, clothes on your back. If you got a little extra, that's great. So it's the whole concept of family and the love that provides, and that structure. And I had that. And so, I never, we weren't wealthy, but I never ever thought of myself as being poor, so it was, so life for me growing up was just good.
How was life with your siblings? Tell my listeners where you fall, how many siblings, and what was the dynamic among siblings as you grew up?
Well, it's interesting. So I was a middle child, but my younger brother was 7 years younger. My sister is 3 years older. But then we had 2 cousins that actually lived with us, who were about the same age as my sister and I, from time to time. So we always growing up with probably about 3 or 4 of us. And then our neighbors had a big family with kids. And, it's, again, the way things are in Jamaica, we were kind of just one, big family interacting together. And, I think that's a great way to grow up, just being, having peers and, folks to learn with, to play with, who are supportive of you. And so that's kind of how it was. So even though it was just one on either side, I mean, really, there was a much bigger network that I was a part of.
Hmm. Okay, so were you a mischievous kid, or you were a targeted kid? Which one was it?
I wouldn't say I was that mischievous, but from time to time, I was a good student, always a hard worker. I would get in trouble from time to time, but for the most part, I paid attention to the stuff that needed to be done in terms of the books and all that. But I also I loved playing. I mean, I played all the sports growing up. I
Okay.
played soccer. I was on the cricket team. You
Oh.
know, yeah. I played some, I played field hockey. I did all the stuff. I loved sports. So that
I
was,
I would not have known that.
yeah.
I would not have known that had I not asked right now. I would not have known that you were an all rounder playing all those, even field hockey.
Yeah. Well, field hockey was a big sport in Jamaica. All the secondary schools, being an outgrowth from being a British colony. So yeah, I used to play that.
That's interesting.
Yeah.
That's very interesting. I'm not gonna ask you if you were good at that because now I think I know what you're really good at. So I'm not gonna ask about what. All right. So at what point? Well, and I know the Calabar thing. We used to see those well dressed young men. In the Calabar, Dunrabin Avenue, Calabar. Stuff like that.
That, that wasn't my Calabar. I went to Calabar all age actually. So
Oh,
from
Calabar Harley.
Woolworth, yeah.
Okay.
I went to
Okay.
Woolworth Boys. Yeah.
Woolmer's. Okay. 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 All right. Okay. All right. So not the older Calabar.
Not the Dunrobin. Yeah.
Okay. All right. All right. So I don't have to ask if you did well in school. I don't have to ask that because if they have to put you out of the house, if your parents have to put you out of the house early, but you can go ask a question to somebody else, then it tells me that you had the inquisitive mind, and inquisitive mind wants to know. And by the way, my wife is maybe one of your cheerleaders here, and she says, "Hi, lovely Dr. Raymond." She's just giving all the put that lovely in there, and somebody down it is saying, "Hello family," who I'm sure maybe you know who done it is, but welcome to everyone who have joined me on Let's Talk with the Doc. And if you have not shared this live stream yet, then I encourage you to share it so that your friends can join because I have Dr. Raymond Wedderburn, surgical professional who is going to tell us a lot about his story. A man who has contributed so much to society. He has gone into the let me use the term the dungeons maybe carefully, just to help to bring healing to the less fortunate. So you'll hear a little bit more about his own story. Born in Kingston, Jamaica, and went to Calabar all age boys' school, and prior to immigrating to the U.S., Dr. Wedderburn completed high school at the New Rochelle High School. Afterward, obtaining his undergraduate degree from Brown University, subsequently earned his MD from Cornell University Medical College, and Dr. Wedderburn completed his general surgery residency at St. Luke's Roosevelt Hospital under the tutelage of Joseph Seveda. Let me ask you, Dr. Wedderburn. Um, at what point, as you said, there wasn't a doctor in my family, so there wasn't one that influenced me. One that said, I want to be just like my cousin, my uncle, my friend. At what point you felt like you wanted to become a doctor before we even get to surgeon?
Yeah. I mean, I would have to say probably somewhere early in high school. I mean, so I had the notion, I think, from very, very young, but certainly I think, first, second form, in that time frame, as I definitely knew that that's what I wanted to do. And again, in terms of the medical profession, I did have a distant cousin who I didn't know, who was in the States, who was a physician, but there was no interaction that made it make any sense whatsoever that this is what I should be doing. But it's one of those things. I mean, I think that if you're in a space where you're allowed to aspire for whatever it is, then you can do that. And I felt like I was in that space, and my parents were supportive. They said, if that's what you want to do, then obviously you need to explore it, figure out how to do it, and then there's no reason you can't do it.
So I'm sure that doesn't just come out of the blue. So I'm kind of curious about what triggers that, what inspires that. If from in high school, a young man just, I want to become a surgeon. Is that from reading, studying, or what was it?
Look, I think that part of the whole notion of helping and all that, it's part of the upbringing. I mean, I was brought up, in a Church of God household. My parents are very religious, and so you're brought up in an environment where the notion is that whatever you do, you want to do something that's helpful, something that you're helping people. So I think that underlying principle, coupled with the fact that I liked math and science, made medicine one of the careers that was something that was out there for me. And as I thought about it, I mean, again, not having a lot of exposure. I mean, in fact, my exposures to medicine at the time, I would say, were somewhat negative. I had this slash on my arm when I was in third grade, that required 17 stitches, and that was not fun. I mean, it was very painful.
Oh, so
So
you actually had a wound that needed stitches.
yes, I did. Yeah.
Okay.
And I wouldn't characterize that as a pleasant experience. So, notwithstanding that negative interaction with the healthcare system, I still wanted to be, in that position where I could directly help people. That's
That
and it stayed with me. It was not, sometimes you have these ideas, and sometimes I talk to kids who say I want to do X, Y, and Z, and the next week or the next month or 6 months later they want to do something else. It truly was my calling. I mean, I never veered from that.
it dawned on you and you stuck to it. And today here you are, how many years after, and you're still sticking to it, and now you've grown into it.
And
Is it,
something
yeah.
I was going to say, there are people. I mean, I graduated from medical school in 1986, so I've actually been a doctor for 35 years.
Wow.
And something, I still love it. I mean, I did one operation today, and it was a joy. Just being able to see that patient who had a particular problem, and to actually solve the problem and help that person get better, to get them back to their family and to their life. I feel privileged every day. Every day is a privilege, an opportunity to help others.
I can only imagine what that's like, and maybe we'll get to some of the connections and the emotions, or and the where, the compassion and the care, because and some of the experiences, what they have been like over the years. Dr. Wedderburn's career focused on providing excellent bedside care while educating the next generation of surgeons. I'm sure we'll hear a little bit more about that, because you have gone to so many places, and I've given your service selflessly to help to educate and inspire others, to become their best. All right, so and throughout his career, he has also been committed to volunteerism, of course, and you'll see that later on, that that is not just for paper, but it's for real, that the man has done it. He has done it. All right, Dr. Wedderburn, tell me. I notice here, as I said to you, in the green room, as we call it, I don't know where to start. I don't know where to start to really get enough out of this time of your contribution to society. I'm looking at your certifications, and I'm seeing Diplomat of National Board of Medicine Examiners in 87, Diplomat of American Board of Surgery 92, Certificate of Added Qualifications in Surgical Critical Care 93, Fellow American College of Surgeons, if in and we and recertification American Board of Surgery in 2002 and 12, and recertification of surgical critical care in 2003 and 13. That's just certifications.
Well, I mean, whatever your career is in medicine, I mean, one of the goals is to be what's called board certified. That's the kind of the high, the highest honor that you can get within your field. So you want to be board certified. So you could train in a field and be qualified, but board certification is that's a benchmark. That suggests that you've done all the work and passed all the examinations required to be considered, an expert in that field. And in most fields, there is recertification required, usually every 10 years. And so what you've just recounted is, it's just my recertification over the course of the years. So I've recertified twice, and guess I'm up to be recertified again next year and in 2023, God willing, in both my areas of specialization.
My wife is asking if any of your patients ever come back to say thank you.
Actually, yes, a lot of them do. And as you know, one of the things I do, I'm a trauma surgeon. So I see patients who never planned to be my patient that day. Right. So trauma is it's whimsical, it's
Hmm.
sudden. Patient, you're going about your business, your day, and something happens, and the next thing you know, you're in my emergency department as a trauma patient, and so I get to see people at their worst because that wasn't part of the plan, um, and so then you take them through the process from there, from the emergency department through all their care to rehabilitation, and actually every year we have a day that's called Trauma Survivors Day when people actually come back. Um, we invite them back because to provide support and to create this big network, this big family. And so that's one of the opportunities where I get to see people and they do say thank you. But patients actually come back. It's incredibly rewarding because you've seen some of these people you've seen at their worst, in a terrible situation, and to see them come back into the hospital, into your office, just to say thanks. It's
Hmm.
incredibly rewarding. Absolutely.
A question that's what's popped into my mind here. Have you ever had one patient that you've seen twice out of accidents or tragedy that you've done a surgical operation on somebody, and somewhere down the road that person showed up again with another situation?
Yeah, unfortunately, that has happened. I think that one of the challenges with trauma, and particularly when I think about the you know um, violence, the violent piece of that, whether it's
Hmm.
gunshot wound or stab wounds, is that even after we patching up the wounds is not the whole story, right? That's really in some ways the simple part of the story. So I can
Hmm.
fix your wounds, but if I send you back to the same environment, then you're going to be at risk for having the same thing occur again. And
Hmm.
so, unfortunately, I have seen that where patients who've been injured that we've cared for, who've survived their initial injury, will come back at some point in the future with other injuries, and it's disheartening but it's one of the problems in our society. I mean, so you can fix the if you fix the body, but you don't fix the rest of the environment, and
Hmm.
that's not a full solution.
That is so unfortunate. That is so unfortunate. Um, okay. Again, I have Dr. Raymond Wedderburn with me on Let's Talk with the Doc, and this man has given his life to helping others, and you hear that, and not only and unselfishly, because not only that he goes to work on his schedule, but he has sacrificed his time um, selflessly to go to different areas to help others, and you will see that as we go forward. And I'm looking at your honor awards, Dr. Redderburn. I'm looking at your honor awards, and there are many. There are many honor awards. Resident Award for Excellence in Teaching, Department of Surgery, St. Luke's Roosevelt Hospital. Luke Alumni Distinguished Young Physician. So that's from 2004. You were a distinguished young physician from 2004. When did you actually get out of residency and gone into the professional field full time?
So I finished my surgical residency in 1991, and then went on to do additional training in surgical critical care, which is intensive care. And
Hmm.
so I finished that training in 1993. So I started my full-time career as a fully trained attending surgeon in 1993, July of 1993, 28 years ago.
28 years ago. And so your awards continued, Mount Sinai, West Wholeness Life Award, Inaugural Physician of the Year Award, Inaugural Physician of the Year Award. And I'm not going to ask what was the competition, or how many people were in were in line for that award. I'm not going to ask that to embarrass myself. I'm going to leave that alone. Okay, so but that's just incredible. Cassie Connolly, Castle Connolly, top doctors, New York metro area. I mean, and it goes on and on and on and on.
I mean, I don't know what to say. I mean, all these things are, I think, are it's humbling. I think so. Like, why do you do what you do? And I do it because I think it's so important. And I think whatever you do, and for especially for the young people, I don't know if any young people out there listening, you know, not everyone has to obviously be a doctor. Not everyone has to even go to college. I think what everyone should strive for is excellence in whatever they do.
Mm.
And there really is no substitute for that. And I think that at work, I try to remember that. I mean, everyone in the hospital is a part of the healthcare team. You know, um, my dad, was a porter in a nursing home. In addition to what he did for the ministry, but we all have a role to play, and so I think that to me, what may distinguish me from some of the other people is probably the way I treat people. I mean, I think I treat everyone with dignity and respect because I think that's the way it should be,
Mhm.
and I try to every day just strive to provide excellent care, to do the best I can for my patients, and to treat all those around me on the team, with respect. And if that ends up with me being honored in some way, I'm appreciative, but that's not my motivation. My motivation is just to get up every day, take good care of my patients, to teach the residents, like I said, to really contribute to that next generation of surgeons. I mean, none of us are going to be around forever, and so you need to prepare the folks who are coming behind you to carry out the task ahead. So
Amen.
that's what motivates me.
Amen. And I'm sure I could say that for myself that you weren't in pursuit of awards or recognition. It's just that it comes out of your contribution as a person who cares a lot for the people who you minister to in terms of surgical care. Um, and I was looking at this document here too, Dr. Wedderburn, and again, I it's impressive. I am impressed with the number of publications that you have attached to your name. And for those who are listening, there are at least 31, at least 31 publications, articles. If I should ask you if you can recall, among these publications, which one would you say, or which two would you say is most riveting, or uh, come from the deepest place in your heart,
Uh,
in your person?
that's it's tough. So there are a couple. I mean, because I think over the years, I mean, I've written with my colleagues on a whole vast number of subjects. But in terms of things that I think were particularly meaningful, one of them is actually relatively quite early in my career. Maybe not that early, probably it's in about 2000s. We did a presentation on what's called percutaneous tracheostomy, um, which is when a patient is on the ventilator for a long time and you need to move the tube from the mouth to the neck.
Mhm.
Um, and so what we did was figure out a way to do that actually at the bedside in the intensive care unit, rather than having to move the patient to the operating room. So
Really?
yeah, because so one, it saves money, it saves resources. It's really a big deal moving these sick patients from one location to the other. So we actually ended up having that paper accepted, and we presented it at a meeting actually in Barcelona, Spain. So it was an opportunity to travel as well. So that was actually that was one of my favorites. I think in terms of others, I've got to look at my list.
No,
um,
no. Actually, that one actually, among the no, I read through a few of them, and that one actually got my attention. The you call it the percutaneous tra-
Tracheostomy.
tracheostomy, right? And that one caught my attention. And I don't know the medical terminologies of all of these things to say, okay, this one jumps out at me, but actually, so tell me a little bit more about that, because other to perform the actual surgery, in the ICU and not in the
Operating theater. Yeah.
operating theater. Tell me a little bit more about that creativity and how that come about.
So it's interesting. I mean, I think that so obviously, if you when you're in the operating room, the operating theater as a surgeon, I mean, it's that's kind of your home. You have all your tools, so that might be where you're going to be most comfortable. But the percutaneous tracheostomy, as opposed to the regular surgical tracheostomy, there's a special set that we use, and it's actually less invasive. So once this was something that I actually brought to our institution after getting some training in that area.
Mm-hmm.
And I thought, well, if we're going to do this and it's less invasive, then perhaps we can create an environment where we can do it safely at the bedside to avoid moving these critically ill patients from one location to the other, in addition to saving them the costs associated with being in the operating room. So like everything else, you've got to build a team and get buy-in. And so it took a fair amount of education and getting the anesthesia team on my side, convincing the nurses that it was safe to do, and then and then we started doing it. And I think whenever you're trying to do something innovative, one of the things that I've learned over the years is the first thing you have to do is you have to build trust. So it's easy to say, well, I can do this, and but I don't think that's not a good place to start. So I think that the best place to start is to build that trust with the team that you're going to work with, and so that's what we did, and we started doing it, and proved to everyone that it was safe, and having done that, we've now done, I think I'd say, well over 1,000 of these cases at the bedside.
Well over 1,000 of those cases.
Right.
So then, I wouldn't even ask the question of how many surgeries you could say, maybe in a range that you have done over all those many years. If you could do thousands of that percutaneous tracheostomy at the bedside. Now, as you said that, I'm curious because you said before you can do something like that, you have to build trust.
Yeah.
And something that it's an experiment, right? It's an innovation. We got to do something that we've never done before, and people normally resist something that has never been done, proven to be effective and safe. What was your biggest challenge at that point?
I think by the time we decided to do this, I'd been there for long enough that I think the nurses. So I think in some ways they're the biggest ones to convince. I mean, they trusted me, and they didn't think I would do something that wasn't safe. But I still think that it's new. They're not comfortable doing. They're not operating room nurses. So I just spent the time, and we just went through the process. We educated them, and we also tried to initially do the patients where it seemed as if it would be easier. So the more challenging cases we still did in the operating room. Because first you have to get people comfortable. So, it's so easy to you can say, okay, well, I'm in charge and therefore I'm going to do this. But that just doesn't work. It doesn't work in the long run. So I think unless you get everyone on board, it's not going to work. So that's what we did. We started with a simpler cases, got everyone comfortable, made them understand that it was safe. I gave some talks. And once you do that and you build the trust and you build a team and show that you're committed to getting it done right, and that the reason that you're doing this ultimately is because it's better for the patient. See, that's the whole thing, right? They'll always buy that. And so if you can convince them that that's the truth, then that will work.
Well, I can understand that, and again, over years, I've proven your professionalism and your record of having done well and gained the respect of those around you. I think that gives a little bit of leeway, even to say, well, if Dr. Wedderburn say it will work, at least we can give it a shot and give him a chance to prove that it works, and then it works, and then the door is wide open.
Right. No, that's absolutely.
Incredible. So I see that you've also done that again in 2004 and 2006. So it's 2002 and 2006. You had that another article on that, right? Another article on the same procedure.
That's right. I think the original one was to the New York State Thoracic Society. So that's 2002, and then in 2006 we we presented at the European Society of Intensive Care Medicine, and that's when we went to Barcelona, I believe.
Okay. All right. Um, Shock and resuscitation in the OBGYN. What about that one?
So that was interesting. So as a trauma surgeon and someone who takes care of patients in the intensive care unit, I mean, dealing with people in shock is fairly commonplace. That's something that we see every day, and so we've evolved ways of caring for those patients and dealing with their specific issues in terms of resuscitation. And by that we mean, what are the things that you need to do to raise someone's blood pressure, right? Because if you're in shock, then your blood pressure typically is low, and there are other issues. And if the reason for your shock is bleeding, then there are specific ways of addressing that. And we evolved something called a massive transfusion protocol, which is where we give different types of blood products in specific ratios to improve the likelihood that patients will get better. So that particular presentation was to the Department of Obstetrics and Gynecology, because postpartum hemorrhage, so bleeding after delivery, can be a really difficult problem.
Mm-hmm.
And for the obstetricians, of course, childbirth is usually fairly straightforward. Most of the cases go very well, and there's nothing to do. But when it does go bad, it can be disastrous. So they asked me to give that presentation specifically to get them up to speed in terms of what the current state of the art was, in terms of what one ought to do, what you should look for, and what the approach should be to try to get those patients resuscitated, if in fact someone develops significant bleeding after delivery. So that was the basis of that presentation.
Wow. Okay. All right, I'm telling you, I'm talking to Dr. Raymond Wedderburn, surgical doctor, and has done a lot. And then we're gonna get to the point where we're gonna look at the places that he has gone and his contribution to society, in the less for the less fortunate, and he will be able to tell you more about that. If you haven't yet share this live stream, that I encourage you to do that. And if you're following and you haven't subscribed to my YouTube channel, I encourage you to do that also, so that you know who next is on Let's Start with the Doc. And with all of those publications, Dr. Wedderburn, you have been invited to do lectures and presentations, and the number of those are just climbing as I look at all of these. I'm going to get into the nitty gritty of what an experience may have been, but the lecturing, and you have gone to places and places. I see here even Istanbul, in Turkey.
Yeah, I can't remember when that was. It seems like that was a long time ago.
That was 2012. That's a long time ago indeed.
Yeah, so this was a meeting of a society of regional anesthesia, and one of my colleagues actually headed up that society and asked me to come and give a series of lectures. And so that was great, both because it's always fun to share your knowledge with your colleagues, but of course it's always also good to see a new place, someplace you've perhaps never been before. So that was a great experience. I think I gave 3 talks at that meeting, and one was a talk on resuscitation. I know one, I believe, was about tracheostomies as well, and I actually can't remember what the third one was, but I know it was. I had to give a series of 3 lectures at that conference, and it was kind of interesting because now we were interfacing with an international group. So a lot of the doctors there were European. And so we don't do things exactly the same way. So it's always interesting to go to these meetings and all these trips. I always learn something. So you might go someplace and you're supposed to be the quote teacher, but I think if you're willing to sort of stop and listen and look, you can you can learn from anyone. And I've learned tricks that folks in environments where they don't have as much, they've come up with very innovative way of doing things.
Yeah, right. Yeah,
absolutely. So you have to keep an open mind always. Be open-minded.
And I know we don't do that from a professional standpoint, from a medical standpoint, with the dangers and the complications that come along with that. But the old Jamaican term say, you turn your hand, you make fashion, you become creative. And going back to the bedside tracheostomy that you talked about, that was also a creative approach, an innovation to say, try something else, right? To experiment maybe, and it works well. And the curiosity of the mind, say, yeah, let's try something, there's a possibility that this could work, and it works so well. I noticed that one of the articles that you have written talks about abdominal compartment syndrome.
Yes. So what is that? So it's how do you describe that? So a compartment syndrome is occurs when there is actually swelling in an area that causes the pressure in that area to increase to a point where it actually interferes with the blood flow.
Mm.
So, for example, if you break your leg, so
Mhm.
if you have a fracture, um, and once the bones are separated, it will tear a muscle, it can tear blood vessels, and if you bleed into the space in your leg, for example, um, and that bleeding is not um, stopped in a timely fashion, it can actually comp- prevent blood flow from going to your feet, for example.
Mhm.
And so that would be a compartment syndrome in the leg. And
Mhm.
for that, we would do what's called a fasciotomy, but basically you have to open the spaces to allow the swelling to expand, so that the blood flow can then continue. So it's not even an interruption in the blood flow itself because the blood vessel is blocked. It's just the swelling itself causes the compression. And the same thing can happen in the abdomen. And I guess the most common place that we see that sometimes with severe trauma,
Mhm.
and we also see that with a disease known as pancreatitis. So patients who have this inflammatory process, inflammation of the pancreas, which is the organ that sits sort of
Mhm.
in the back of the abdomen, um, and that's where you make your insulin,
Right, right.
and that sort of thing. So those patients get so sick that they need a lot of fluids, and it actually can cause enough swelling that you literally can cut off the circulation to different organs in the abdomen. And so that's what that article was about.
Okay, okay, okay. Man, I tell you, again, for those who are just listening, Dr. Wedderburn has, up to this date, that those are on the record, 31 articles that he has published in different medical papers or magazines, or whatever you want, a description of that. That is incredible. All right. So we're gonna come now to some of the volunteerism that's part of your common nature, and let me say that I have been honored to get to know this man personally, on a level of you know ministry. God has blessed me that He has brought people in my life from all different eras of my life during my journey, and that allows me to be able to talk to a man at this level this evening. And for those who don't know, I'm sure his mother has got to be listening somewhere this evening, because she's just a proud lady, and we join her. And I'm sure your sisters have to be listening somewhere, because they are so proud of you. All right, they're so proud of you, and we are all proud of you. And I'm just happy to get to know you on a personal level, and I can share this time with you. All right. Um, I have noticed that volunteer presentations are numerous as well. You have a lot of volunteer presentations, and let me just look at how many are on the paper that I have in my hand here. Um, 29 29 voluntary presentations. Tell me about the voluntary presentation. These are not articles written and published, but these are voluntary presentations. And I'm gonna and let me just say to the Jamaicans that are here, that he has been to Jamaica a number of times, and we will get back to that because Jamaica is the man's root, and he has been around. So he's gonna tell us a little bit more about of his voluntary presentations, his traveling, and hey, let me tell you, this man never stopped traveling. This I don't even know how he does it because you can't find him. I don't know how he does. He has a job that he works so hard at his job, but you can't find him. I told him earlier that I had to use a net to catch one fish. I had to use a net to catch one fish, and I'm just so delighted that I get a chance to talk to this man because I don't know if it will ever happen again for the rest of the year or next year. This time, that's how hard it is to get this man. So tell me about your global health outreach mission. Ecuador, Tabara, Nigeria, Dominican Republic, Jamaica. Just tell me a little bit about your global mission outreach.
Yeah, I mean, I guess it's the saying, it's to those to whom so much is given. You know, if you have an opportunity, you should try to give back. And I always think of that little. So if I can help somebody as I travel along, then my living will not be in vain. Obviously, in work every day, you're helping, but there's so much need. The global burden of disease is incredible, and the global burden of surgical disease is also huge. It was not it used to not be on the front burner. I think the emphasis was always on malnutrition and infectious disease,
Mhm.
and those are really the big issues. But surgical needs across the world are tremendous. And so one of my goals, once I finished my training, was actually to do whatever I could to give back. And if that meant that I went on a trip once every couple of years, then great. But it took a while to get started because I think you go through the phase, you're paying loans off, you have all these other issues. But once I got started, I mean, it was over. So once I went on the first trip, it was I was determined to really try to not have a year go by without going on the trip. Unfortunately, because of COVID, I haven't been on the trip since 2019. But I tend to do 2 or 3 trips a year, whatever I can, and I'm willing to go wherever if it's safe and there's need, and based on my conversations with the people or the groups, I think I can contribute, I will go. And so in that context, as you can see, I've been all over the world on missions. I've been to Africa, Asia, South America, obviously the Caribbean, going home. And the thing about that is just that, again, there's need everywhere. And if you can go and bring some resources to try to help those folks, then it's a good thing. It's a good thing.
Mm. As you talk about, COVID has altered, so many areas of our lives, and as you talk about that, you haven't been able to go because of COVID. I remember, as from a chaplain perspective, when you're talking to a patient, one of the questions that you ask, how does that make you feel? You know, how does that make you feel? How that make you feel in not being able to do this to fulfill your passion for a whole year because you've been traveling numerous times per year.
Yeah, so on the one hand, it was hard, but on the other hand, the need in front of me was so tremendous. I mean, so it was, again, as they say, it was a no-brainer, because unfortunately, what we saw, particularly in the first wave, last March, April, May, June, uh,
Hmm.
was just so devastating.
Yep.
So the task ahead of us, just in terms of trying to figure out how to care for those patients, was just it was monumental. So to me, it was a sort of thing, you have to talk to yourself, because I think that a lot of people really suffered through this crisis and are still suffering. But for me, it was, I was so fortunate, so blessed to be able to do all the things that I'd done before COVID. So I was, well, if I never went on another trip, I still have all these these memories to look
Hmm.
back on, all the trips that I did, all the folks I was able to help. So it was just a putting it in perspective. So for me, it was okay. I can't do this now, but there's a lot of work to be done right in front of me, right here at home. And so let's focus on that task. And if we can get beyond that, then I'll go back to doing my mission trips.
So you were comfortable that you have stored up a lot. So if push come to shove that you couldn't do it now, you have stored up a lot. You didn't waste the time and the privilege that you had. You used them effectively. So if I was not able to do it now, I would be comfortable in my skin because I didn't waste my opportunity in doing that.
Exactly. Time waits for no man.
Time waits for no man. Time waits for no man. As you talk about the trauma thing, I wanted to come back to uh, and you talk about the question we talk about the abdominal compartment syndrome. And I know of or I've heard of, and people have accidents. Sometimes it's gunshot, sometimes it's different things, and they have head injuries,
Right.
and sometimes to allow the brain to swell, they have to remove the scalp or
Yeah.
the cup to allow. Do you do that kind of do you brain surgery, head surgery, and that kind of stuff, or
Right. So no. So we work with
a surgeon?
our neurosurgery colleagues. So the way our trauma system works is that all patients that are brought into the trauma center. So we're a level 2 trauma center. So all patients who are brought into the trauma center who meet the criteria for coming to a trauma center are seen by my team. And so we participate in the initial management to figure out what their injuries are, and then we get the assistance of additional specialists as needed. So for someone who comes in with a severe traumatic brain injury, we would get our neurosurgery colleagues
Okay, okay.
involved in their care, and we would jointly manage them, because unfortunately most of these patients have multiple injuries, so it's not just one thing. And so one of the challenges in the beginning is A, identifying the injuries, and then B, deciding what the priorities should be in terms of managing those injuries. Because so someone comes in and there's a severe injury to the brain, but by the same time, at the same time, they have a ruptured spleen, a broken pelvis. And so we have to coordinate that care and try to make sure that we do things with the appropriate priority, so that we can actually optimize the chance that that patient will survive and recover.
Wow. Dr. Raymond Wedderburn, 30 something years? 30 something years?
Doing what?
Doing in the medical field, right?
Yeah, 35 years out of medical school, but and 28 years fully trained and practicing.
And you look at this man, and he looks like what? You look at this man, he looks so young, right? That's incredible because he takes really good care of himself. And I don't know how he does it. Is always gone, always at work, or always gone. I have no clue. I have no clue. I don't know if it's just genetic or what, but boy, I don't know. I don't know. And by the way, I see somebody. I passed. Mom and I are listening. Somebody is listening. So, okay, Mom and I are listening, and I had no doubt that they would be listening. I guarantee that they will be listening because they are as proud as it could be, and you know how much they love you and appreciate and respect you, and all of us who have gotten to know you feel the same way about you. Even though we're not blood brothers, but I feel that kind of level of connection. um okay, so I have noticed that you have also gone to you have a special place in Jamaica where you go, right? That's where your mission take you. That's a special place in Jamaica. I was looking for some various some variation, but as I count, I see like I go to the same place. So you hit one spot and spread it out from there.
Yes. So the group that I go to Jamaica with, well, actually, here's the interesting story behind that. So
And
if
by
you,
the way, before you respond to that, I finally see something from MD Clark here. I finally see something from MD Clark. I'm sure you know who that is. That
uh,
is so very proud of you. I'm sure you know. You and I know who that is.
So the Jamaica story is interesting because I started going on all these trips and I never went to Jamaica. And part of the reason for that is that our people are tough. It was hard to get stuff set up down there. And one of my colleagues, who was an anesthesiologist, also from Jamaica, we had fits and starts trying to establish something down there. And in fact, the way I ended up going to Jamaica was one of my nurses at the hospital. She really gave me a hard time. She let me have it. She goes,
Really?
you're going to all these places. Why you don't go home to do something? And I said, I've tried, but it hasn't worked out. And it turns out that she had gone to Jamaica with this group, and so she got me the contact information for the leadership of the group. I contacted them and asked them if I could participate, and the rest is history. So I went with them probably about 6 years ago, and I've been going ever since. And the person who was in charge of the surgical section of the mission subsequently retired, and so I've sort of taken over coordinating that aspect of it. But it's a great group. It's called the Jamaica Awareness Association of California, of all places.
Mm-hmm.
And when we go to Jamaica, there are a bunch of different facets to it. So one, there's a surgical piece, but there are a lot of medical doctors who go to all these little clinics all over. It's mostly along the northwest of Jamaica. But we have an educational group. We go to schools and we give scholarships to kids. You have kids who, as you know, they pass the test. I'm not sure what it's called now, what used to be the common entrance, but They can't afford the books or the uniform. So, you can sponsor a kid. So for example, I'm sponsoring a child for 6 years, so, and it's affordable. But brilliant young lady. But if there wasn't someone who could help pay her, for her books and her uniform, she wouldn't be able to take advantage of that, despite the fact that she's brilliant. So the group does a lot of different things, and it's a privilege to go home every year and to really try to contribute and to see if you can help build some infrastructure so things can get better.
That's interesting. I'm talking to Dr. Raymond Wedderburn, a good friend and family of ours in our circle, and I'm so honored to have gotten to know this man who is a surgeon of upper class, a surgeon of upper class. All right, I am going to come right back. I'm going to do a bit of add on my book, and I'm going to come right back and continue my conversation with Dr. Wedderburn. So stay tuned, my friends. That book is a good time to get a copy. You might just find it very, very interesting and edifying. Dr. Raymond Wedderburn. All right. Your connectedness to it's anatomy. Is there some, because there's always, everybody needs somebody someplace. Is there was somebody pull a string in another baby? Because I know some people have some connection to another baby kind of thing, So I'm just kind of wondering if there is some connectedness that, okay, finally we can find an open door here in anatomy.
Yeah, so something like that. I wasn't the one who initiated that. So initially, when the group, the JAAC, the group that I go with, started going to Jamaica, there was no surgical component to it. They were doing just medical things and dentistry and the educational piece. And so when the surgical mission started, the doctor who started it, a gentleman by the name of Dr. Weeks, he's a Trini, who went to Jamaica and worked with us. And so he had met the person who was the what is it called down there, the SMO for Inatave, who was a surgeon, and they discussed what the needs were for Jamaica, or what he would like to see as an innovation, and they wanted to learn how to do basic laparoscopy. So, laparoscopic surgery, as folks probably know, it's doing surgery through small incisions. Some people call it keyhole surgery, but it's a great innovation in that if we can do it, so it minimizes the trauma to the tissues, so patients actually recover much faster. So that became sort of the flagship hospital in terms of doing laparoscopic surgery in Jamaica. And so since it started there, even though we would branch out and go to other hospitals, we would always send a team to Unwavering. So that's why you see that on the list every year. So we always go there, even if we go elsewhere. We've gone to Salve, we've gone to out to Portland, we went to Mandeville 2 years ago. So we'll go to other places, but that's always been sort of the central,
like your entry point.
Exactly. Yeah.
Okay. All right. Now that's clarified.
Right.
Okay, that's clarified. So it's like, okay, I land in Montego Bay Airport, but I've gone to Negril and I've gone to Morant Bay and I've gone. Okay, all right, got it. That is settled. All right. So thank you, man. Let me ask you. Over your experiences. I'm gonna come to one. What would you say was one of your most difficult, challenging, traumatic surgery that you had to do? Something that, although you have done thousands of them, but something stays in your mind that every now and then you have flashbacks on that. Is there one or two that you can say, man, this one was really really challenging and it was really life threatening, or boy, when we put this one back together, it was incredible.
That's so hard because people always say, what was your biggest operation? What was your longest surgery? Or what?
Right.
And it's so hard. I mean, because I can tell you that over the course of this very long career that I've been fortunate to have, there have been so many impressive, interesting, serious cases. But I can give you a couple of examples. I mean, I think one from recently. I think earlier this year during COVID. I mean, it may have been like the end of last year, beginning of this year. I took care of a young woman who was riding on the back of a motorcycle that was, hit by a car, and she was thrown from the motorcycle. And we had our highest level activation, what's called the trauma code. So all the resources coming to the emergency department to try to figure out, literally how to put her back together again.
Mm-hmm.
I remember looking at her, and I don't remember, she's like in her early 20s. I remember looking at this young woman in our trauma bay and thinking, I'm not sure if we're going to be able to get her through the night, based on the degree of shock. Her blood pressure was so low,
Mm-hmm.
and given that mechanism, being hit on a motorcycle and being thrown, knowing that she was going to have a bunch of serious injuries, and so I think I spent the next 8 hours with her. First we activated our massive transfusion protocol because she was bleeding a lot, so we had to give her a lot of blood products.
Mm-hmm.
And then going immediately from our trauma bay to the operating room, doing an operation to stop bleeding from her pelvis. And we took her from there to the radiology suite for them to do a special procedure to actually put certain material into certain blood vessels to stop bleeding from the pelvis. And from there, we went back to the operating room to do another operation to stop bleeding from her spleen. And from there to the CAT scanner to identify all her injuries, and then to the intensive care unit. And, so then about 8 or 9 hours later, I'm actually standing by her bedside. And one of the injuries that she had was something that could be actually lethal, where your skull is actually separated from the rest of the vertebrae.
Goodness.
So the risk of actually completely shattering your spinal cord is so high. And there was no way for me to tell if she had that or not because she was still so sick and sedated. And so after 8 or 9 hours of working on her, I kind of walked out of there a bit depressed, not being sure if she would even wake up. And she's made a full recovery. It's
Yeah. She made a full recovery.
full recovery. It took a lot of work, probably 20 operations, not just by me, by orthopedics fixing the bones and all these other injuries that she had. But it's those cases that help you sort of keep moving the ball forward. You have to give it your all, and
Mm.
you don't know what the result's going to be, but you just have to do everything that you know how to do, and sometimes you have to make it up. You really do end up sometimes in situations that they're not like things that you've seen before, and you have to be innovative and see how things work out. So that was one of those cases, and I just saw her a couple of weeks ago. We had our Trauma Survivors Day that I mentioned earlier uh, in the middle of May, and she was on the Zoom call, and she's doing well.
Oh, so you actually be able to see her and to communicate with her on a Zoom call.
Yeah.
Wow. Yeah, I come back to the regular chaplain question. How does that make you feel? I mean, you've said it because it motivates, it inspires, it encourages, and it tells you that while there is life, there is hope. And so what I hear you say is that even before you could do a scan to find out the extent of the injuries, there are some things that needed immediate patching up.
Exactly.
Even to do that, you have to kind of put those together to hold things together before you can even go to find out the extent of the damage or the wounds. Or wow,
That's the way it is, and
that's incredible.
yeah, and that's a success story. I mean, obviously, over the course of 28 years, there are some stories that do not end well, and
Yeah.
that's it's difficult, and particularly when you've been caring for a patient for a while, you get to know the family. Um,
Mm,
it's
mm.
very hard. That never gets easy, and I always tell my trainees, if it gets easy, then you should find another profession. Um, so it should hurt, and it's hard, but you have to you deal with that. You have to learn from it, try to incorporate what you learned, and use that in the next patient in a similar situation.
I know from a professional standpoint, from a counseling level, and I'm sure from a chaplain level, and I'm sure from the physician's level, surgeon level, the principle would be the same. You try to, while being human, compassionate, caring, you try to detach your emotions personally from individual situations so that you can effectively minister to the person in whatever area of care or support or counseling that you're doing. Have you ever found it hard to detach yourself from a particular situation, even from the professional standpoint? It impacts you so intensely from a human standpoint that it was hard to detach yourself from it, even though you were still being professional.
Yeah, I mean, on occasion that happens. I mean, I can still remember one situation. It was a young man who had um, been injured. I believe it was a gunshot wound. I don't remember, but basically, I mean, I had operated on him, and I remember I had actually gone on vacation a few days after, and when I came back, he was quite ill, and we worked and we worked and we worked over the course of probably a couple of weeks, and got to know the family. He
Mm.
had two sisters who were always there for him, um, and ultimately, we lost him. And I just remember that, you know, when he died, I just lost it. I mean, I was there, just crying with the family. I mean, it's just, and fortunately, it was at a time and in a situation where I didn't have anything else that I had to do, in the next 5 minutes, and you know, and yeah, and yeah, that's what happened. Um, and I think there are times in this career when unfortunately, even though we're all human, you don't have the luxury of actually allowing yourself that emotional release at that time,
Hmm.
and we have to learn how to compartmentalize, because on a given night on trauma call, someone comes in and I go into a resuscitation, and we do everything we can, and that person dies. Um, if I've got to sort of pull it together, because 5 minutes later there could be another person. I mean, 2 weeks ago I was on call, and we were in the one person came in with a gunshot wound, and we went to the operating room, and you know before I was even finished with that operation, there was another one. And so I had to go down. I had to call in the backup surgeon. So you have to on the one hand, we're human, and it's okay to be a human, and it's okay to
Nothing is wrong with being
yeah,
human.
yeah, yeah, and so it's okay to understand, empathize, and sort of commiserate with families. But obviously, there are times in the course of providing care where you really, and particularly with what I'm doing, you just have to compartmentalize. You have to shut it off, take care of the next thing, and then you have to come back and deal with it. Because if you don't, then that's not good, right? So emotionally, you really have to process the events that occurred, but
Hmm.
sometimes just not at that time.
Hmm. And this question has popped into my mind as you said that, because we're all human, and we have our moments, and some things, for whatever reason, sometimes we look at a situation and we might say, I've seen worse than this, and it didn't affect me in the way that this one affects me."
Right.
Because sometimes it depends on, I'm just speculating that it may depend on what your day is like, where you are emotionally in that moment, that or what you've been dealing with prior to. Something may have softened your emotions, and then you get to this point where, oh my God, I run into this thing that I can't shake off. But my question is, in moments like those, where do you turn? Where do you turn for support? Where do you vent? Where you lay your head? Where do you turn to for help or support in times like these? A friend, another doctor, surgeon. Where do you turn?
Yeah. I mean, we have a good team, and so I mean, I have colleagues who are very supportive, and so we talk about these things, and I think that one of the challenges, I think, for everyone is trying to get yourself in an environment that's as supportive as possible, right? Because if you're
Mhm.
if you're not in a supportive environment and you're dealing with some of the stuff on your own, then that's can be very damaging to you emotionally. Um, but fortunately, I think we've created an environment that's incredibly supportive, and so yeah, we have these challenges, and we talk about them. And so if I'm in one of those moments, I feel fortunate to have colleagues that we can just we can just talk about it. We can air it out, and people can be real with their feelings about what's going on, and you try to process it that way. So that's the way I deal with it.
Amen. I'm talking to Dr. Raymond Wedderburn. This is a great man that I have known for a number of years now, and I've grown to respect even more, and just to learn, even look at the documentation, and to know the human contribution to society. It is incredible. I consider him to be a phenomenal man who selflessly. And if you just joining me and you didn't hear the beginning or the earlier part of this conversation, you need to get this on demand so you can hear all of it. He has 31 articles on medical terminology issues, and things that happen to people that he has contributed to society. So, um, um, Dr. Raymond, tell me about your mission. Tell me, where would you which of your missions trip that you might say you have gone into a situation that you would say is one of the most challenging, from a medical perspective, medical standpoint, environmentally, accessibility, resources, that kind of stuff.
Yeah, it's actually easy. Liberia. Um, So that, I believe, was 2013. And that was one of the most difficult trips, just from a resource standpoint. I mean, they'd been through a civil war, and they just hadn't recovered. So we were outside of Monrovia, the capital, so maybe an hour outside a little town called I think it was Waiala, and just again, we were operating in this makeshift. Actually, it was part of a church converted into small operating rooms, and trying to do the best we can with with limited resources, and it was just tough. And I think we did the best we could under the circumstances, but it was tough. And as you know, I've been on a lot of different trips, but that one stands out for just the difficulty getting things done, because there was just such limited infrastructure. And trying to do is, I mean, again, you're doing surgery, so you have to try to do things safely and under sterile conditions to minimize the risk of infection. And we're only going to be there for a week, so there are people who will follow the patients afterwards. But just trying to get to the point where you felt comfortable doing certain things. So it's kind of interesting, because when we go on these missions, one of the challenges is actually trying to figure out, it's not what you can do as a surgeon, it's actually what will the mission, what will this location tolerate? Because if I do an operation, could have been carried out perfectly, but you don't have the resources or the facilities to take care of that patient in the recovery phase, then it's no good. So one of the things that I learned after, one of my early missions, where we had an issue. I mean, we did a big operation because they'd saved up this difficult case to do with us, and we did this operation, and then at the end I said, okay, so now we go to the ICU, and they just looked at me and go, "There's no ICU."
Oh, wow.
And I said, okay, well, the patient's still on, he's still got the breathing tube in. So, okay, so where's the ventilator? And they said, well, there's no ventilator
Oh my goodness.
outside of the operating room. And fortunately, I had two of my intensive care nurses with me, and we just stayed with the patient for 6 to 8 hours until he was awake enough that we could take the tube out. But it was an important lesson. It's not what you can do, it's what the environment will tolerate. So on all the missions, one of the first things I do is try to do a needs assessment, and you look at the facility, you talk to the people you have to work with, and try to figure out what you can actually safely do. It's not what you can do, it's what you can safely do.
That is interesting, because as I listen to that, I can only imagine, having done completed a successful surgery, but the environment, the situation, what's left behind, the care, the aftercare,
Right.
to make sure that the person healed properly and all of that kind of stuff, to avoid infection and all that kind of stuff. That is incredible. That is incredible. Do you remember? Can you recall, other than what we see here, how many places that you have been and do other, not just lectures, but they talk about hands in the dirt, getting down and dirty.
You mean? Are you talking about just general travel, or specifically for?
No. For surgical purposes or medical reasons, not just for pleasure,
Yeah.
or for lectures, but to get down, hands on.
Yeah. I don't know. I think I don't know what the number is. I honestly, I don't really keep track. As I say, if someone calls, and I can create the time, and it sounds like it's worthwhile, and after speaking with them, it seems like I can contribute, I will make an effort to go. So I don't put any limitations on that. If it's safe and it seems as if I can make a contribution, I'm willing to do it.
Having said that, let me ask you, because being as busy as you are on your job, how do you schedule the time away to be involved in different places so many times per year?
Well, part of it's like I make the schedule, so
okay.
so that helps. And a lot of these trips are are planned well in advance. So, like the Jamaica trip is usually the first week in June. I mean,
Oh,
that's sort of standard. So I know when that's going to be. One of my colleagues who's from the Dominican Republic is involved with the Dominican Medical Association, and their trip is typically in March. So I have the dates from far for some of the trips from far enough in advance. I mean, obviously if there's a disaster, like as in Haiti, you just you drop what you're doing, and and if you can get the time, you go and help. Um, but for a lot of the trips, I mean, these are things that are planned in advance, so I just plug them into the schedule. That I'm going to be
guess
away
what?
that week. Yeah,
Guess what? This is the first week in June.
I know. COVID.
So if it wasn't for COVID, there's no way I would have.
Exactly. It's on my schedule to be in Jamaica, but yeah, COVID. Yeah.
I'm not gonna say thank God for COVID. Maybe we'd have to work something out some other way and see if we can squeeze you in someplace. But I'm glad that at least we get a chance to talk to you in spite of COVID. Um, how do you how do you see the COVID thing affecting your profession? In what way you see changes up or down during this COVID period, and what are those changes?
Yeah, yes, it's been very interesting. So for one thing, one of the really really obvious things, there was no flu this year. Nobody had the flu.
Nobody
Why?
has flu.
Everyone's wearing a mask.
Everybody.
I mean, we literally had one flu case the entire flu season at our
Oh,
hospital.
wow.
Yeah.
Wow.
So that's one thing. I think that attention to some of the basic things in the hospital, basic hand hygiene, things that you should be doing anyway, but that people sometimes weren't as careful about. I mean, that's ramped up. And so some infections are also way down because of that.
Hmm.
Um, it's I think that for in a lot of the environments, teams have actually become closer. I mean, we've seen so much death,
Hmm.
um, so much heartbreak in this past year, and for my staff, particularly the nurses in the intensive care unit, it's just been devastating because they've been taking care of the sickest of the sick.
Right.
Um,
Right.
so one of the things that I think that I've seen, at least in my environment, is that we've just become sort of closer and been more supportive of each other, which is a good thing. Um, you know, there are things that have changed that will never go back. Things like Zoom. you know, it's kind of interesting because pre-COVID, I used to miss a lot of meetings because we have two hospitals. And if
Hmm.
I'm busy, I can't. You can't get to the other hospital. Maybe now with Zoom, you just get on the call. Um, so it's interesting. I mean, it's obviously, hopefully, a once in a lifetime thing for us. I mean, this COVID. I think there are other potential things out there that we might see, but hopefully not in our lifetime. Uh,
Hmm.
but it also reminds us that the world is small, and we are in fact our brother's keeper, and we need to keep that in mind. That anything that can affect someone in one part of the world can actually affect us, and we need to be more mindful of that and think more about what we can do to help each other, instead of just living in our own silos.
And as somebody say, as someone says, until the world is safe, we are not safe.
Absolutely, absolutely, it's true.
Until the world is safe, we are not safe. Man, it is so good to talk to you. It's so good to talk to you, Dr. Wedderburn. I am so proud of having you as somebody I could talk to if I need to talk to somebody. I really do appreciate that, and I thank you for joining me on this let's start conversation. So what would you say? The question I wanted to ask that kind of moved my mind. That if somebody is listening and this broadcast and is contemplating having resentment, having skeptic about the COVID vaccine,
Yeah.
what would be your suggestion to somebody who might be logging in between, should I, shouldn't I? What would be your advice to somebody who is contemplating, weighing whether should I or shouldn't I take the COVID vaccine if it's available?
Yeah, I mean, it's obviously a very personal decision, and I respect people's decisions. But having seen people my age, younger than me, no pre-existing conditions, die from this disease, and having seen what's happened with the vaccine, there's no question in my mind that A, the vaccine is effective, and B, barring, I mean, and that if you have access to it, you should get it. I mean, I can tell you that the first, obviously the vaccine rollout started, the end of last year in December.
Right.
The first January, February, March, April, we had 70 to 90 patients with COVID in the hospital. We could never get our numbers below that. Because that included transfer from other hospitals in the Mount Sinai health system.
Mm-hmm.
With the vaccine rollout and wide wide utilization, we're now down to single digits. For the last 2 weeks, we've had less than 10 patients with COVID in the hospital.
That is incredible. That is another success story.
Yeah. So I just want to tell people, I mean, that the vaccines are, I mean, they're safe. I know for a lot of people, Black and brown people, they have legitimate concerns about what's happened with the medical establishment in this country. But this is not one of them. Okay, let me tell you. I mean, like, all those people who have all the money were trying to cut the line to get these vaccines.
I know, right? And that's what we heard. People are paying big money just to get in front of the line that they can get in and run away and feel safe.
Exactly. So I think they're effective and they're safe. I mean, I think people worry about, you hear about some of these side effects, and they're real, but they're side effects. People take aspirin, they take Tylenol. Those things have side effects.
Mm-hmm.
There was the one thing with the issue with the blood clots with the Johnson & Johnson vaccine. It was like 6 people out of 7 million.
Oh, that's
That
7
is
million.
not even a number.
Right.
Okay? And so, and it was also specifically, women between the age of 21 and 40. So if you don't fall into that age group, it doesn't matter anyway. But it's also such a small number. So the reality is that there's nothing that's going to be 100% safe. But these are very safe and very effective vaccines. And, and I mean, I had people who say, even nurses who say to me, well, I want to wait and see. Well, we're 6 months out and we're seeing more and more evidence of how effective they are. So I would just encourage you, to really think about it, because the truth is, unfortunately, that the virus does not discriminate. Okay, and if you get it, and you get a bad case, then we still don't have a lot of tools to treat it. So and it's pretty clear that the vaccine itself is great at prevention, or if you get the disease, it's much, much milder. I mean, I have a friend, and a personal story, another physician who has a condition that actually affects her immune system. So she got the vaccine, didn't have the greatest response, and she got COVID, but it was mild. Had she not got the vaccine in combination with her underlying condition, I think she probably would have died. So, so to me, in a way, it's a simple decision. I mean, and my feeling was, as soon as it was available, I was going to take it. So I got the Pfizer, the first dose in December, second dose in January. And I've been vaccinated now for 5 months, and and I still take care of patients, some of whom have COVID, and mercifully, I mean, I didn't get it before the vaccine, and I've not had any issues since then.
I'm with you. I got my both Pfizer in February 6th and February 27th. I got my first and second shots, and I've been doing fine. And I'm happy that I have it, that I got it, and it gives me a sense of safety, and even if I should get the COVID maybe again, then the result is, according to the findings or the data, that you would not be hospitalized, let alone die.
Right.
So that's a good thing. All right, Dr. Wedderburn, what would be your final word to tell somebody that somebody who's aspiring, somebody who is dreaming, and what would you say to somebody who is dreaming and is contemplating, should I go after my dream? Is it achievable? Should I push myself? What would you say to somebody who is contemplating that, who are aspiring for dreams?
So, so absolutely, you should push yourself. So I think that the key thing is, you know, you're trying to figure out what it takes. You need to have the information. So explore what's necessary to achieve the goal. And then once you've done that, then the next step is to try to figure out, what are the tools that you need, and then how can you possibly go about getting them. I can tell you, I mean, listen, my parents didn't have any money to send me to these schools that I went to. I mean, it wasn't going to happen if that's what I was going to count on. So, once I figured out what it took, and listen, I mean, they worked their hardest to try to help me as much as they could. But they also, they'd given me the tools and, made sure that I knew how to study and how to get the information. And then you go out and you do your best to get whatever resources you need to accomplish that goal, and don't let people stop you. I mean, I think it makes me crazy still that in 2021 there's still people telling black and brown people that, oh, you can't be a doctor, or you can't do this, or you can't do that, or why don't you do this instead? I mean, there's nothing wrong with being a respiratory therapist, a nurse, any other part of the medical field. But the point is, if you want to, achieve the highest level, and that's what you want, don't be discouraged by someone else. Okay, figure out what it takes to get there, and go for it. I mean, the sky is the limit, and I think that you aim for the sky. Okay, if you miss, maybe you get the clouds. Don't aim low.
Right? Yeah, I agree with you. I agree with you totally. One of my thought is that just like you're not dead until you stop breathing, your dream is not dead until you stop dreaming. So
Absolutely,
keep on dreaming.
absolutely.
Dr. Raymond Wedderburn, I am excited. I am so thankful that I get a chance to talk to you. I know there's so much that we could have. We haven't even talked about. You've gone to 80 a couple of times too, right? Or at least
Just once after
just
the
once
after the
after the earthquake.
yeah,
Okay,
yeah.
okay, okay. So you're so we consider you an all rounder, not only in the sports, but you're an all rounder in terms of journeying and journeying, writing, performing surgeries and articles and lecturing and mentoring.
Yeah, I think that's very important. That's to me like, and I'm really at that point in my career. I mean, I've always tried to do it, to be a mentor, but I really see like this next phase, whatever is granted to me, is really to try to give back and to do what I can to encourage and foster, you know, other individual, in particular, black and brown kids who don't have the opportunities, to try to help them see a way into this profession, because we need them. I mean, no one's going to take care of us better than us. Um,
Mm.
so I think that we need to do it, and I consider that part of my mission. One of my big goals for this next phase is to try to encourage and mentor as many people as I can.
Wow. Thank you so much. You're a prime example of what it takes to be successful. I couldn't be more proud of you. Just knowing you and your hard work, your dedication, your commitment, your consistency, the range of your contribution is not like one dimensional or with the biases, but you've spread it. You spread it as far as you could while you are able. And as we said earlier, that if you weren't able to accomplish your regular routines during COVID, but you were still comfortable because of your contribution over the years. That if I didn't get a chance to do something this year, I my conscience would still be in a good place because I didn't waste opportunities. I made good of those opportunities, and now I could make myself comfortable. Thank you, Dr. Wedderburn. Thank you so much.
Thanks for
We
having me.
are proud of you. I am happy to have known you, and I know for those who didn't know, the brother is hard to get. He came up. He came. He told me he walked out after surgery straight home to his office and logged in to join me on Let's Talk. Believe me, I am honored. I am honored that he would have done that. So I'm not gonna hold him any longer. He need to get his rest and get ready so he can be alert for the job tomorrow. All right. So, Dr. Wedderburn, thank you for joining me. And you're going to stay right there. And I'll come back and say goodbye to you off here. But, my friends, if you're just joining me, you can listen to this program from the top all the way through once I close out. Whether you're on Facebook or you're on YouTube, you can still listen it and you can share it with your friends if you think it's inspiring and it's motivating. You can share it with your friends and your family. And if you haven't subscribed to my YouTube channel, it's a good time to do it now. Or follow me on Facebook so you can know who is going to be next. Because with God's help, I'm going to always have interesting people joining me on Let's Talk with the Doc. All right. So if you haven't gotten a copy of my book, here's a chance to get a copy. Well, my friends, if you haven't yet gotten a copy of my book, The Seven Churches of Asia Minor, or The Church in Revelation, it's time you get a copy now. You would learn something from it, I am sure. It's good for Bible study, good for a book club, or just for personal reading if you just want to know. An inquisitive mind wants to know. Available on Amazon, Barnes & Noble, all the major bookstores. Or go to beckford.com and you can get an autographed copy from me, or email me orbministries@gmail.com and we could set it up. You could get yourself a copy right now. All right, so we're gonna close it out. Thank you, my friends, for joining me. It's been my pleasure to have you. Thanks for your thoughts and your prayers and your wishes. Thanks for the suggestions and the comments about Dr. Wedderburn and his great contribution to society. And the family members who have joined us are so proud of you, Dr. Wedderburn. I'm sure you'll hear it from them. You know, when you close out from me, you'll hear it from somebody. Somebody's gonna call you, somebody's gonna text you, somebody's gonna say something. Oh, Raymond, 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 right? Yeah, yeah. And then somebody say, cuz, we're gonna hear it. So God bless you, my friend. I thank you for joining me. And until next time, my friends, I will see you. Stay there, Dr. Redderburn, until
Thank
we
you.
say goodbye. All right. Well, thank you for checking in on ORB Ministries. I trust that you will share with your friends, subscribe, hit the bell for notification, and stay tuned because you never know what's next or who will join the conversation.